They say that beauty is only skin deep, but ugly goes to the bone. Dermatology. Oh my God, what are these disgusting hands? Take a look at these hands. And so what do we have? We have velvety brown, velvety dark brown, hyperpigmented skin lesions associated with obesity, associated with diabetes, associated with colon cancer. Sometimes it's acanthosis nigricans. And it is a hyperpigmented lesion that is found in the axilla, sometimes around the neck, down here, down the neck, and the antecubital fossa, and this grayish, brownish, velvety textured velveteen rabbit associated with GI malignancy, and that is your most frequently asked question. It's associated with GI malignancy, diabetes, and obesity. So we can't say what causes acanthosis nigricans because we don't know what causes it. We just know that it shows up at the same time as diabetes and colon cancer. Velvety, nice, smooth, and that is acanthosis nigricans, simply an association. Oh, what is this? Whoa, let's see. Oh, look there. Oh, the angles of the mouth, in AIDS. It's at the angles of the mouth, and it's in AIDS with relatively low T cells, not all the way down the bottom T cells. This is not under 50, not under 100, but HIV, and at the angles of the mouth. This is angular cheilitis. What an interesting word. It's at the angles of the mouth, and cheilitis, angular cheilitis, is a fungal infection, but it's not lesions in the mouth. It's not like thrush. You don't need to have lesions in the mouth. Angular cheilitis is a fungus. It is a candida, and it's a candida at the angles of the mouth. It can also happen in people who have high sugars and bad oral hygiene because it's a sign of overgrowth. Bad hygiene, and people who have some minor immunocompromise. It makes the yeasty beasties grow. And since it's yeasty beasties in HIV, you can treat it with antifungals. Antifungals like fluconazole, or the topical antifungals that you just put a little on the angles of the mouth like dish. Angular cheilitis. It's a fungus in HIV and immunocompromised people. It is candida, and you use conazole, terconazole, miconazole, fluconazole, clotrimazole. It's minor, it'll go away. Now, these lesions here, ooh, kind of smooth and shiny like a pearl. What is this smoothish, this shiny like a pearl? Not hyperpigmented. It'll be described as slow growing. Most accurate test, well, this is dermatology, so in general the most accurate test is always a biopsy. There's always a biopsy here, so, smooth. And the management of all skin lesions that are particularly malignancies is biopsy and remove, and biopsy and remove, biopsy, remove. So what are you going to do for these skin lesions? Biopsy, remove. It's a basal cell carcinoma. Now what we have to notice is that these lesions are shiny, pearly. They're not hyperpigmented. They're not ulcerated like a squamous cell. They're not hyperpigmented like melanoma, and you remove them and slice them off. Now, basal cell is very slow growing, so just slicing it off will take years and years for it to regrow, and that's all you have to do for basal cell carcinoma. So it happens, you notice, low pigmented people, sun-exposed areas, pale people, sun-exposed, pale people, shiny like a pearl, shiny like a pearl, shiny like a pearl. Biopsy, remove, basal cell carcinoma. Ole, 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 ole. Now, it's, what is this? These are cafe ole spots. What a great name, right? Would you like a cafe ole spot with a cherry hemangioma? Or maybe a strawberry tongue on top of chocolate agar. Well, medical foods, cafe au lait spot, milk with coffee. That is neurofibromatosis, which some of you may call von Recklinghausen's. Yeah, neurofibromatosis. They are neurofibromas, lots of spindle shells. And you have cafe au lait spots, which are hyperpigmented lesions that are basically present since the time of birth. Now, there's no medical therapy because they don't have symptoms, they don't get worse, they don't turn into melanoma, they don't turn into more evil things. Cafe au lait spots, they're an association with neurofibromatosis. They're hyperpigmented lesions with neurofibromatosis, and you just have to know that they are there. And these are the neurofibromas. These flesh-colored things are the neurofibromas. These are lots of spindle-shaped cells around neurons in the skin. And this is more cafe au lait spots. And this is more of a cafe au lait spots. And these are just you seeing association with neurofibromatosis. Neurofibromatosis, here's the step 1 question. You see, the step 2 and 3 question is simply, can you recognize neurofibromatosis? Can you recognize cafe au lait spots? Step 2 and 3 question is that you understand there's no specific therapy for it. It's very practical. Step 1 also says, do you understand that there's a specific genetic defect on chromosome 17? That there's autosomal dominant transmission? Would you recognize a Lish nodule, which are hamartomas of the iris, if you saw it? Lish nodules are hamartomas of the iris, and they're all associated with neurofibromatosis. Pheochromocytoma goes up in neurofibromatosis because it's part of the same chromosomal genetic defect. This is a very hard one to be able to say, what is this and what disease is associated with it? This is an epiphenomena of another disease. This looks like it's herpes. It looks like it's herpes, but it's not herpes. It's dermatitis herpetiform and it's associated with celiac disease, gluten-sensitive enteropathy. It's associated with IgAs attacking the skin, with IgA attacking your duodenum and bowel. This is dermatitis herpetiformis, has vesicular fluid-filled, itchy lesions. What's the difference between saying itchy and pruritic? Ooh, about $42,000 worth of debt. That's right. I didn't go to medical school to say itchy. I could have said itchy for free. I went to medical school to say pruritic. Now, these lesions are not on the mucous membranes like herpes is. It's on regular dry skin, not around Mr. Happy, not around your mouth or the vagina, regular dry skin, and the only test that you can get is a skin biopsy. Now, if you're not certain what the person has, if for some reason the celiac disease has not been diagnosed yet, if for some reason you don't know what the person has for other reasons, then you would have to biopsy the skin, because the biopsy of the skin is the single most accurate test where it shows IgA in the skin. Well, you might say, how is that not Henoch-Schönlein purpura with GI joint, skin, and renal, GI joint, skin, and renal with Henoch-Schönlein purpura? Well, the answer is that Henoch-Schönlein purpura gives you abdominal pain and GI bleeding. Oh, but this gives you abdominal pain. Ooh, that does look a little like Henoch-Schönlein purpura. Oh, but Henoch-Schönlein purpura gives you joint pain too. Gives you joint pain, and the other part about this is that dermatitis herpetiformis is not in mucous membranes, and you have to biopsy it to know for sure. Now, why dapsone works, no one knows. Why does dapsone, the anti-Hansen's disease, the anti-leprosy drug dapsone, the anti-pneumocystis drug dapsone, well, why does dapsone work? And the short answer is, I don't know. But this is dermatitis herpetiformis 2-1, and this is dermatitis herpetiformis. There's vesicular lesions, but it's not on the mucosal areas. It is IgA deposited in the skin. And the only management of this is to control the celiac disease, control the gluten-sensitive enteropathy of celiac disease by knocking the wheat out of your mouth. Time to knock those buns out of your mouth, and that's the only thing that makes it get better. Remember, The easy wrong answer is to say steroids. After all, this is dermatology. Isn't that half of dermatology? Biopsy steroids, biopsy steroids, biopsy steroids. But this will not get better with steroids. Dermatitis herpetiformis. Now, what is this? Oh, blue-toed one. What is this? Oh, blue toes. Well, these blue toes are from gangrene. This is sudden vascular insufficiency. The most accurate diagnostic test is an angiogram, but this is gangrene. This is a clot to an arteriole, and all you can do is anticoagulate and remove the clot. Now, it won't reverse what's happened unless you catch it really, really fast, but this is gangrene of the toes, which is exclusively from vascular insufficiency, in particular in people who have diabetes, which is very, very, very prone to vascular insufficiency. Gangrene is a clot in the artery. You catch it acutely, heparinize and remove the clot. Anticoagulate and remove the clot. Anticoagulate and remove the clot. So if it happens suddenly, what it is, it's acute arterial insufficiency. You threw a clot there, you threw a clot. If it's acute, anticoagulate and remove that clot if it's acute. Now, the diagnosis is the same things that you use for vascular insufficiency in terms of saying, why did they get it? Ankle brachial indexes. Remember, the blood pressure should be equal in your ankles and your arms. But the most accurate test, the only way to know for sure of any vascular structure, the single most accurate test of any form of vascular disease is a vasculogram, angiogram, arteriogram. Do you notice these drugs, that this is the same sort of drugs that we use in the heart and the brain for a stroke? Right? But cilostazol is not. Cilostazol is an antiplatelet, antispasmodic medication. Cilostazol is an antiplatelet, antispasmodic medication. Cilostazol is an antiplatelet, antispasmodic medication that is one disease and one disease only, peripheral arterial disease. It has one disease and one disease only, peripheral arterial disease. Gangrene results in the loss of a limb. It is a vascular amputation. And the only way to fix it is to pull that clot out of there acutely before you lose your toe, like this dead toe on your left, or these dead toes on your right, or this dead foot on the bottom. This is acute vascular insufficiency and gangrene, and the toe gets lost because these are mummified toes. There's no point, if these look like they have osteomyelitis, in treating for osteomyelitis. There's no point in treating for osteomyelitis because these toes have to go. They have to go. They're dead. I'm sorry you could walk really well last week. Now you can't. Oh, what is it? What is it? What is it? Who gets it? African Americans. But what is it? And we don't know what causes it. And we hope that steroids work. These are keloids. Keloids are overgrown skin tissue, overgrown fibroblasts, usually in African Americans, and it's the result of hypersensitivity to skin damage. You have minor skin damage, and 6 months and a year later, the scar continues to grow and to grow. Now, the scar continues to grow and to grow and to overgrow. In other words, it doesn't know when to stop. So a keloid is not a cancer, it's just an overexuberant fibroblast response. Keloids are an overreaction of fibroblasts to minor skin trauma, and basically it happens in scars and it happens in people of color, and all you can do is give some intralesional steroids. We inject the lesion with steroids and hope it stops the growth, but you know, the hard part is the only way to definitively get rid of them is to cut them off. But what caused it? Cutting. Oh, that's a problem. Cryotherapy and radiation sometimes work. Trying to freeze it, freeze it, or radiate it. We don't know precisely what causes keloids. It's the same way I overreact and I overcompensate. It's like if I decide to get hair implants. Like, why are you overgrowing something? It's truly not yours. And ultimately, if you can't do anything with it, if steroids and radiation don't work, you actually have to take your chances and cut them out. But the problem is they regrow. The problem is you cut them out and the keloids, the fibroblasts, will regrow. This man had to have his cuts off. This is the before on the left. Before, after, happy, keloid. Next one, what is this? Those are some nice fishnet stockings you're wearing. And she says, I'm not wearing fishnets. That's livid reticulum. Livid O means bluish. Livid O means bluish. Reticularis means network. Livido reticularis means a bluish network of blood vessels. It's a bluish network of blood vessels. This is livido reticularis. What is associated with it? What's the treatment? So here again, even in this part of dermatology, we're never far from our basic questions. What is the most likely diagnosis? What is the test? What is the treatment? Diagnosis, test, treatment. Derm. Diagnosis, test, treatment. Derm. That's it, baby! That's it. Livido-reticularis is a vasculopathy. It's a constrictive vascular response to cold. Mottling. Livido-reticularis, the reticulum is a $5 word for net. Now, livido-reticularis is also in association with some severe arterial insufficiency. It can be from cryoglobulins, hepatitis C, antiphospholipid syndromes, but it doesn't change the management, which is we don't really know what to do for livido-reticularis. But what's critically important is that you know that a person with livido-reticularis needs to be evaluated for hepatitis C. Livido-reticularis, like porphyria cutanea tarda, needs to be evaluated for hepatitis C and cryoglobulins. What is the difference between a cryoglobulin and a cold agglutinin? The difference between a cryo and a cold. A cryoglobulin and a cold agglutinin. A cryoglobulin and a cold agglutinin. Well, they both seem to happen in the cold. But cryoglobulins is associated with livido-reticularis. Cryoglobulins causes this mottling of your skin. Cryoglobulins can cause renal problems. Mottling of skin known as livido-reticularis, mottling of skin known as livido-reticularis, and also cryoglobulins, renal skin, and cryoglobulins and hepatitis C. Cold agglutinins causes hemolysis. That's what cold agglutinins are. Next one. So remember, this is associated with cryoglobulins too. Cryoglobulins. Okay, cryoglobulins and livido-reticularis. Thank you very much. What is this? Well, I know it's asymmetric. What is this? Well, we know it's irregular colors. We know it's irregular borders, irregular colors, irregular borders. It is diagnosed by biopsy, shave biopsy, or full thickness punch. Shave or punch? And the answer is punch, all the way through. All the way through. Now, the testing and treatment of all skin cancers is by biopsy with one exception. What's the only skin cancer that we don't want to biopsy? Because it's very vascular. It's got vascular networks through it. So we don't like biopsying because it bleeds. That is human herpes virus 8, which causes Kaposi's sarcoma. Human herpes virus 8 and Kaposi's sarcoma. And that's which one is not biopsied. All the other biopsied. This is melanoma. All the rest are biopsied. There's an asymmetric shape, an uneven border, an uneven color, change in diameter, asymmetrical shape, uneven border, uneven color, change in diameter. It is a melanoma. The most accurate is a full thickness biopsy because we know that the depth of the lesion from top to bottom, from top to bottom, from top to bottom, that depth of the lesion from top to the bottom has colossal pathologic significance. If you have a tiny, thin little layer of melanoma, you're not going to get hurt. However, a person who has 2-3 millimeters of depth is going to metastasize and die. Full thickness is critically important because all of the prognosis in melanoma is based on the total top to bottom height of that lesion. The lesions that are thin can be cured much more easily by slicing them off. Thicker lesions metastasize to strange places like your eye, your brain, your nail beds. Eye, brain, nail beds. And you treat melanoma like all skin cancers with the exception of Kaposi sarcoma, which is very vascular. You treat squamous cell, biopsy, remove, excision. Basal cell, biopsy, remove, excision. Melanoma, biopsy, remove, excision, slice it out. Interferon, this is one of the last remaining indications for interferon. Most people don't realize exactly how much interferon has gone out of style and out of use. And that is because it doesn't have that many places where it has better efficacy. And it's certainly, interferon is very uncomfortable to use. Interferon injections, like intralesional chemotherapy, can be effective, but chemotherapy is given in addition to surgery, used in addition to surgery. Unlike basal cell and squamous cell, basal and squamous are all surgical pathology. But melanoma has medications and it also has some chemotherapy. So we see now it's asymmetric, uneven borders, uneven colors, uneven borders, uneven colors, uneven size, uneven colors, uneven colors, uneven borders. Does not stay the same size. It changes. Let's absorb. A, B, C, D. Oh, and the total depth. That's why needing to know how far down, how far down, how far down do you have to cut is a big deal, because all of the prognosis and everything that we're going to do for melanoma is based on knowing the right depth of the lesion, and that guides your chemotherapy. You see those black dots? That black dot's there? That's pigment in the skin with melanoma. Okay, you see these black dots up in here? They're up in there, weird stuff. Okay, oh, you see the black dots? The black dots? Black dots, black dots? This is melanoma, and these are the abnormal pathologic specimens of melanoma in a skin lesion. I'm Conrad Fisher, and I approve this message. What do you see in this person? This one is not as obvious as the others. This one is not as obvious as the others because you can't see all of the lesions. Skin colored, what is it? The most common neurologic abnormality with this, you see skin-colored, heaped-up lesions. What can you do for therapy? When you have neurofibromas, those are neurofibromas. This is von Recklinghausen's disease, and this presents with 8th cranial nerve tumors because the Schwann cells around the peripheral nerves hypertrophy in the canal and make you deaf. So this is hypertrophic Schwann cells around the 8th cranial nerve squeezing it off. It's like meningiomas. It's like a meningioma. Now, what happens is that you can get seizures and disability. Now, they're uncommon, but the question was, what neurological problem is associated with this? And the answer is seizures and learning disabilities, okay? But they're uncommon, so it's uncommon, can be. Now, there's ultimately no therapy for neurofibromatosis except for the skin lesions are really terrible to take, visually, there's really not much to do about it. For instance, you can't do medical therapy for this person. You can try and remove them cosmetically, but these are all neurofibromas. They're flesh-colored, skin-colored, soft, squishy. They're flesh-colored. What you get is that on the pathologic specimen, what you get is stuff like this, plexiform, like a plexus, a collection, plexiform neurofibroma, and what you're going to see on it is all sorts of spindle cells. Here's the pathology of neurofibromatosis. Here's the pathology of neurofibromatosis, spindle cells with fibrillary cytoplasm, and you see these long, thin, elongated nuclei. See the long, elongated nuclei? That's very von Recklinghausen's, very neurofibromatosis. You can see them all over the thin, elongated nuclei, but you have to come in for higher power to be able to see those elongated nuclei, just like these, just like that, stretching the nuclei of the fibroblasts. What is this? It is poison ivy. Now, poison ivy, let's look at it again. It's poison ivy. It's poison ivy. Now, poison ivy can go around the body as a hypersensitivity reaction. It's a contact dermatitis. Is it immediate? Is it type 2? Is it type 3? Is it type 4? Poison ivy is a delayed hypersensitivity reaction, and it happens a day, even a day later after the exposure, because this sort of reaction doesn't happen fast enough to need steroids. You use cold compresses and calamine basically to dry it. Symptomatic relief is the short answer, and if it gets really bad and really uncomfortable, then the management is some steroids, topical steroids. This is poison ivy that's really bad. And some people get tremendous coverage with these kinds of lesions. Can be very uncomfortable for people just from poison ivy. Now, poison ivy is a type 4 hypersensitivity reaction. That means cell-mediated. That means slow. That means you can be inhibited with cyclosporin. You can be inhibited with cyclosporin because this is cell-mediated immunity. And the antigen-presenting cells are going to go to the T cells in the lymph nodes and send out neurotransmitters and cytokines. Poison ivy. Dendritic cells, or T cell antigen presenting cells, are going to be able to activate a delayed hypersensitivity reaction a day or two later. What is it? Ooh, I see silvery, scaly stuff on my extensors. Silvery, scaly things on my extensors. What is this? What's the test? What's the treatment? What's the test? What's the treatment? And doesn't it look like psoriasis? It does look like psoriasis, because psoriasis means silvery, scaly, flaky material building up on the surface of the skin. That's psoriasis. Now, the multiple, let's see those, by the way, again. See that? Silvery, scaly, hypersensitivity reaction. Yes, but hypersensitivity to what? We don't know. It happens mostly on the extensor surfaces, giving these silvery, scaly plaques. And there's lots of treatment, but there's not much knowledge precisely about what is the antigen that psoriasis is reacting to. We don't know. We treat with steroids, and when the steroids thin the skin, what we do is we can use vitamin A and D. Vitamin A, vitamin D, calcipotriene, vitamin A and vitamin D. We use topical steroids. Salicylic acids remove the superficial scales. Now, what happens with vitamin A and calcipotriene, which is vitamin D, is that vitamin A and D derivatives are a more benign, gentler way of handling skin on a long term. Because using high potency steroids for a long time is very damaging to skin. Because did you know that over 90% of the amino acids in your skin can be converted to sugar with gluconeogenesis? Did you know that? Most people don't. They can be. And if you have chronic steroid use, you're going to find out because it's going to melt you. Now, if you have widespread disease, we'll use ultraviolet light because widespread disease means it's up and down and all around, and it's almost impossible to cover that large a surface area just with topical steroids. TNF inhibitors can be used if you have such refractory disease that even ultraviolet light does not work. Adalimumab, etanercept, infliximab, adalimumab, etanercept, adalimumab, etanercept, infliximab, adalimumab, infliximab, etanercept. These are the TNF inhibitors, and they keep you off of steroids. What is it? It's on the extensor surfaces. What is it? It's on the back of your neck. What is it? It's Kebner phenomena. You scrape it and overreacts. It's Kebner phenomena. You scrape it and overreacts. Whoa, look at that silvery, scaly stuff. It's terrible. Oh my goodness. What is it? It's psoriasis. Psoriasis is a T-cell mediated hypersensitive reaction where you have all sorts of extra skin built up on extensor surfaces, and it actually makes its own blood vessels. It makes its own blood vessels. Has an association with HLA-C. Now, the T cells, the ones that are deficient in HIV, well, the people who have psoriasis have T cells that are overreacting. Interleukin 12 and TNF and all these cytokines. Now, this is going to look a little bit like a mess at the beginning. That you have dendritic cells, then you are going to the skin, then you're activating CD4 and CD8s, and you have a whole cascade of cytokines putting the immune system into action. Oh, let's hear it. Here are the TNF inhibitors. Adalimumab, etanercept, infliximab. And this is a graphical response of the immune system, showing you what type of reaction. Now, to what antigen? We don't know. Now, this is, ooh, it looks disgusting. It looks like a pizza that got left out overnight by mistake. This is pyoderma gangrenosum. And pyoderma gangrenosum is associated with inflammatory bowel disease. Pyoderma gangrenosum is associated with inflammatory bowel disease. Oh, here's the other thing. It's also the answer to the question, when you treat inflammatory bowel, which of these manifestations does not resolve even with the treatment of the inflammatory bowel? And the answer is pyoderma gangrenosum. Erythema nodosum gets better. Pyoderma does not. What's the other thing that won't get better despite treatment of the inflammatory bowel? Even if you take the colon out, you still will not get rid of this, okay? Sclerosing cholangitis. Sclerosing cholangitis. So pyoderma gangrenosum and sclerosing cholangitis are the two things that won't get better even if you treat the inflammatory bowel disease. It won't get better. Now, it can be in both Crohn's or ulcerative colitis, but remember, Crohn's involves the colon in 40% of people. Crohn's involves the colon in 40% of people. So the extraintestinal manifestations like erythema nodosum are the same between both of them. Pyoderma gangrenosum are the same. And no matter what causes it, pyoderma gangrenosum and sclerosing cholangitis will not get better even when you treat with mesalamine, 6-mercaptopurine, azathioprine, TNF inhibitors. It still won't solve the problem with those two things. Now, it's also associated with RA and sarcoid, chronic hepatitis. And the management is simply to control the underlying disease and given some intralesional steroids. And basically, we don't know what to do. We don't know what to do. I just know that I'm necrosing, zombie leg, Whoa-wee, when the moon hits your eye like a big pizza. Never mind. So the thing is that these things, disgusting, aren't they? They don't get better with treatment, and that's the big take-home message. Pyoderma gangrenosum, you can treat with steroids, you can treat with ASA derivatives, you can treat even with TNF inhibitors, but pyoderma and sclerosing cholangitis don't get better with treatment. What is it? It is kind of benign looking. It's a benign skin lesion. The most accurate test is generally nothing. We don't biopsy these because they don't look evil. You only biopsy things that look evil, not semi-evil, not quasi-evil, not the margin of evil. But biopsy the ones that look evil. Now, if you're not certain whether that's a bad-looking seborrheic keratosis, is that a bad-looking seborrheic keratosis? Or is this possibly a skin cancer you missed? Well, you may not be able to tell entirely by visual appearance, but most of the time you can. Seborrheic keratosis is quite clearly benign and quite clearly associated with older white people, basically. And it looks like it's been stuck on, like you threw toilet paper with poo up against the wall. Because, although it's a unique experience to biopsy, and biopsy is the most accurate test, it's not necessary for seborrheic keratosis. It is the answer for seborrheic keratosis to the question, what is the most accurate diagnostic test? Now, you don't have to treat them except cosmetically if you don't like the way it looks, or you're going to lose your health insurance. You want to get a whole bunch of tests like, I don't know, biopsy something. Cryotherapy can be effective because basically cryotherapy, anything you don't like in the body and you want to get rid of in your office, you inject it with minus 70 degrees liquid nitrogen. All right? Oh, what is it? Why, it's seborrheic keratosis. Next one. Look at that skin in multiple different colors. Look at that skin in multiple different colors. It's a tinea. What's the most accurate test? Well, the most accurate test for tinea versicolor is scrape it for potassium hydroxide, scrape for potassium hydroxide, scrape for KOH, and fungal culture. That's the most accurate test. Generally speaking, tinea versicolor is a superficial fungal infection. This is the organism, Malassezia furfur, Pterosporon orbiculare. Can't even say that, can you? Pterosporon orbiculare. Malassezia furfur. Malassezia furfur. Yes, and what you do is you scrape it for KOH and put it in fungal culture. Generally, it's the most accurate. Now, these hypopigmented lesions that can be multiple colors, that's the name. Multiple colors, versatile colors, and that's how you know what it is. So the organism basically inhibits the transfer of melanin. Why do you get hypopigmented? Because it's screwing up your ability to transfer melatonin, and the skin doesn't tan. So you do a potassium hydroxide on a scraping, which looks like spaghetti and meatballs to some people, and you treat it with a topical antifungal, unless it involves hair and nails. But tinea versicolor generally stays just on the skin. Now, these are filaments and spores of organisms that with the scraping you can see the spores and you can see the filaments. The topical antifungals are what you use in general for tinea versicolor. And the only hard part is that when you have to cover a whole huge person, for instance, me as an average sized guy, I'm over 2 meters of body surface area. What happens when you have that large? You can use selenium sulfide or ultraviolet light. Selenium sulfide or ultraviolet light. This is tinea versicolor, and this is the bug. Micro! Yo, micro! Oh, look, these are the bodies. These are the blastoconidia. These things are non-septated. So since they're non-septated, that gets the term pseudo-hyphae. These are the blastoconidia. These are the pseudo-hyphae. Next one. Ooh, what's this? Been masturbating with the back of your hands again? No. This is hypopigmentation with no other disease associates. This is hypopigmentation, not associated with anything else. This is vitiligo. And vitiligo is basically an idiopathic loss of melanocytes. We think there's some abnormal T cell activation, and we don't know. That's the short answer. The short answer is nobody really knows what causes vitiligo. You all of a sudden get not comfortable in your own skin. You start saying, "Get me out of here! Get me out of here!" Autoimmune disease. But we don't know. We just know we don't know what causes it, because why do you get addisons? I don't know. It's not Waterhouse-Friderichsen. That's not happening. It's not tuberculosis. That's not happening in the United States at all anymore. It just happens. It just happens. Addisons. I'm allergic to my own adrenals. Diabetes. I'm allergic to my own pancreas. Hemolytic anemia. I'm allergic to my own red cells. And thyroid disease too. Because remember, Hashimoto's thyroiditis is a circulating antibody. These are all associated. They're part of extracellular immunity noise, because it's the same person that also has antibodies against their intrinsic factor, hint, 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 anti-intrinsic factor and anti-parietal cell antibodies, okay, is what you get in B12 deficiency. B12 deficiency, okay? Now, the other part about this, what people don't realize, is that your whole goal in vitiligo, since it's benign and it's not going to hurt you, is just do the most benign thing. Don't tan. Stay out of the sun. Hey doc, it hurts when I do that. Don't do that. So at least it avoids the contrasting by trying to use some steroids. You know, so at least it avoids the contrasting by trying to use sunscreen. At least it avoids the abnormal contrasts that make it so obvious between the normal and hypopigmented skin. Topical steroids, yeah, why not? This is dermatology. You don't know what to do? Biopsy steroids, biopsy steroids. And the thing is that many people, knowing that it's very hard to make the hypopigmented skin dark, it's hard to make the light skin dark, because no matter what happens, you have an autoimmune disorder eating those melanocytes. Then what you do is you chemically peel off the rest of the pigmented skin and become more white. These are Xantha. They are our most accurate test. Doesn't need a test. These are xanthelasmas. And xanthelasmas are a type of xanthoma. Why do we have that word X? Why don't we just use the word Z? I've always wondered that. Then again, I don't even know why panties are singular and bra is plural. So, type of xanthoma, this is basically occurs around the eyes, and it is lipid, it's butter, it's a fat built up around your eyes often in xanthelasmas by the fat leaking out into the surrounding tissue and getting picked up by macrophages. So there is no specific therapy for a xanthoma. And the therapy is to control the underlying hyperlipidemia. Soft and squishy and asymptomatic. Soft and squishy and asymptomatic. The most accurate test, there is no test. You take those things which are called lipomas and remove them. Remove them. These are lipomas, a ball of fat. Fat balls. Fat ball in my arm. Fat ball in my neck. Gonna cut it out before I go to heck. Oh, I got cheese pizza. It's in my neck. Yeah. And how do I know it's cheese? Because this is the fat that's in the microscopic. This is the histology. And you see mostly these clear things. Welcome to histology, because these clear things are fat cells. Because fat cells, adipose tissues, are baggies of lipids. They're like water balloons of lipids. You ever throw water balloons at people? I used to all the time. So, water balloons of lipids and goo. This one looks like a stained glass window, doesn't it? But it is lipids in goo. It is massive amounts of fat cells in lipoma. And the lipoma has no tests because it has no malignant potential. It doesn't go anywhere. It doesn't have any tests because you just feel it. It's not hyperpigmented. And the answer is you remove it if it is cosmetically uncomfortable, or you just don't like the way it feels, or nobody like having fat balls bumping up against you in strange places. You remove it cosmetically, and if it becomes irritated, but not because it's going to cause anything. Lipomas don't cause cancer ever. Dermatology. See you in the next section.